what are the indications for surgery, and what are the different types of surgical modalities you can apply for management of simple bone cyst. So, why do you need surgery in unicameral bone cyst? And the answer is, it is for prevention of an impending pathological fracture, or if the child has already presented with a fracture, it is to achieve union in an acceptable alignment. So having said that, how to identify as to which UBCs require surgery, and to understand this, I look at a simple 4-point checklist, namely, what is the site of the lesion, what is the size of the lesion, is the child having pain, and number 4, what is the cyst activity. And let's take up each of these points one by one. Regarding the site of the lesion, so if it is a UBC involving the lower limb, then probably the threshold, my threshold for offering surgery decreases as compared to a cyst in the upper limb, understandably. Furthermore, if it is a cyst involving the proximal femur, then this is probably the only absolute indication for surgery in case of UBC. So proximal femur surgery should always be operated. The next point is the size of the lesion. Here again, it's a very simple formula. If the cyst size is more than 85% of the transverse diameter of the bone, then these cysts should be operated because they are at high risk of fracture. Furthermore, if the cortical thickness is less than 0.5 millimeter, then you should offer surgery. Pain. Why pain is important? Because pain indicates that the child is having a fracture. So macroscopically on X-ray, you may not see a clear-cut fracture line, but if in children with UBCs, you are having pain, if you do an advanced imaging, you will see that there are microfractures. And therefore, pain is, if the child is having pain, you would more incline towards surgical management. The last point is cyst activity. So what do you mean by cyst activity? So active cyst is one in which the cyst is abutting the physis, whereas latent physis is one which has grown away from the physis, and therefore the cyst lies in the diaphysis. And why cyst activity is important? Because active cysts are known to have a higher rate of fracture, and they are at a higher risk of increase in size. So having discussed these indications for surgery, let's understand as to what are the modalities with which we can treat. Now again, these indications are not absolute indications. So if you look at this algorithm, which was published in a review article in 2022, what you can see over here is, apart from proximal femur fractures, in all other scenarios, the choice of surgery is a shared decision making with the parents. So you have to discuss with the parents the pros and cons with the surgery, and only then the decision regarding surgery should be taken. So apart from proximal femur fracture, there is no absolute indication for surgery in a UBC. What are the different surgical options available? So broadly, they can be divided into intralesional injections, cyst decompression, curettage and packing, and internal fixation. Let's understand these one by one. So intralesional injections means you inject some substance percutaneously into the lesion. Most commonly what you inject is steroids. So injection methylprednisolone is injected about 250 milligram. However, the problem with steroid injection is that it most often leads to incomplete healing even after multiple injections. And furthermore, there is a 15 to 85% recurrence rate after 3 injections. So steroids, they have to be given with, caution. You have to explain the parents that multiple injections will be needed. Furthermore, the failure rate is significantly high. The other option is you can inject autologous bone marrow or demineralized bone matrix. The advantage of a steroid is that these have osteogenic potential. However, there is no real, good data to prove superiority of these materials over steroids. The other surgical options are cyst decompression. So in this, you can do an extramedullary decompression, meaning that you rupture the cyst wall, you drain the cyst fluid, and therefore you relieve the high interstitial pressure within the cyst. This can be done by perforating the cyst wall either with a wide bore K-wire or J needle, or what you can do is you can simply insert a large cannulated screw into the cyst. What this will do is, through the cannula of the screw, the cyst fluid will keep draining into the soft tissue. This will relieve the pressure within the cyst and bring about healing of the cyst. Intramedullary decompression you can do by inserting a tense nail. By this, what you're doing is you're connecting the cyst cavity with the medullary canal, and therefore the bone marrow can then, get access to the cyst cavity, and it can bring about healing of the cyst. The next option is curettage and packing, and therefore in this you can pack with either autologous bone graft. So you can first perforate, you can curate the walls of the cavity and then pack with graft, or you can use graft substitutes. The advantage of the graft substitutes being that you can avoid donor site morbidity. Finally, in certain scenarios where the cyst can be unstable, mechanically unstable, you need to provide stabilization with internal fixation. So in proximal femur lesions, you generally use screws with side plates. In other lesions, you can use tense nail as initially described. So broadly speaking, these are the surgical modalities which can applied in UBCs. Not all UBCs, remember, need surgery. Proximal femur UBCs must be operated. Aim of surgery is prevention or treatment of pathological fractures, and choice of surgery depends on individual case considerations.